My name is Phoebe James. I'm a Professional Development Officer with the Hunter New England and Central Coast Primary Health Network. Before we get started, I'd like to acknowledge the traditional custodians of the lands that we're on today. I'm coming to you from a Awabakal land and pay my respects to elders past, present and emerging. This morning, we have Liam Clifford presenting for us, and I'll throw over to him to tell us a bit about himself. Thanks, Liam.
Yeah, no worries. Thanks for having me. I'm happy to present today. Yeah, so I'm an endocrinology advanced trainee at Bankstown. I'm actually dual training with general medicine. So I'm about halfway through both my programs and have an interest in things like diabetes, metabolic disease, bone disease, do a lot of osteoporosis. So what I thought we could do today is we'll go through the new guidelines that have been released for GPs on osteoporosis. We can touch on just some general things about working up osteoporosis, the medications and therapies available, and then how we can sort of navigate around the PBS to be able to provide the treatment you want to for your patients. And I guess who to consider treating and who not, because it can be quite a subjective landscape. I'm happy for people to stop me and ask questions at any time. I've got some cases at the end that we can go through as well. All right. So I thought I'd show this. So this is taken from the new guidelines that were just released recently. You can see there's a lot of information on it. The purpose of this is they're trying to work out a framework, I guess, for how you can stratify risk for patients who you think have osteoporosis, and then how you go about treating them or investigating them. I guess there's a couple of things to draw attention to this. So one is that for the purpose of these guidelines, the way they describe minimal trauma fracture is a little different to how the literature and how we would generally describe a minimal trauma fracture, and I'll go through that in a moment. But you can see that just based on this flow chart, a minimal trauma fracture that involves either the hip or your back leads to the treatment algorithm, whereas if you have any other form of minimal trauma fracture, it's recommended that you go through and screen with DEXA and do other things. So that's one thing just to be mindful of. The other thing is they also talk about risk factors for loss of bone density, which we'll go through a bit later. However, this is not really covered on the PBS aside from steroids, and I'll mention how we can sort of manage that. So just a couple of important things in this flowchart that are a little bit different to the PBS and also how we would manage patients in clinic generally. So look, it is recommended that patients over the age of 50 who sustain a minimal trauma fracture should have a presumptive diagnosis of osteoporosis. The issue, I guess, is if you're under 50 and you have a minimal trauma fracture, and we know that there are patients that you'll see in your clinic who do suffer a minimal trauma fracture and you can't explain why, it's difficult to label someone who's under the age of 50 with osteoporosis. The main reason for that is we just don't have enough studies or evidence that have looked at that cohort of patients. So we would normally refer to them as patients who have sustained a minimal trauma fracture or who have reduced bone density. It does make treatment a bit more difficult. However, when I go through some of the PBS criteria for some of the medications, you'll see that age is not always a cutoff. And so that's worth bearing in mind. So how do we diagnose osteoporosis? Look, you probably all know this, but there's two different ways you can make the diagnosis. One is a minimal trauma fracture. That's essentially any fracture that occurs when you would otherwise not expect it to occur, particularly in the setting of no trauma or if someone falls over, for example. There are exceptions to this. So at the moment, we don't include any ankle fractures. So whether it's a Weber A, B, or C, that's no longer considered a minimal trauma fracture. We don't consider the carpals in your hand as minimal trauma fractures due to their size. No fingers, no toes. The skull and your cervical spine also are not considered minimal trauma. It is a bit controversial, but a rib fracture is generally now considered a minimal trauma fracture, even if it's a single rib. The reason is that that probably just indicates that there's an underlying predisposition to fracturing, even though it's in a very vulnerable position in the body. The other way you can make the diagnosis is if you've got a bone mineral density T-score less than or equal to minus 2.5. The exception to this, if someone's on steroids for at least 3 months, then that all you need is a T-score of equal to or less than minus 1.5. It is important to note that on that flowchart I showed you a couple of slides ago, The current GP recommendations actually suggest steroid exposure for 4 months, but the PBS recognises 3 months, as do most guidelines. So that's what we'll work off today. So when do you do a DEXA scan? Look, I've listed all the PBS codes here. It might be useful. Essentially, you can do a bone density scan on anyone if you suspect that they've got a condition that predisposes them to bone loss once before the age of 50. So we often see young people in clinic, particularly females who have got, chronic kidney disease, they've had a renal transplant, maybe they've got celiac disease or hyperthyroidism. You're allowed to do a bone density scan on that patient cohort to look at their bone density. If you start someone on treatment, you can do it again after 12 months because you want to see if there's a significant change in their bone density. Generally, what we do is we do one at baseline, one year after we've treated them, and then we do it every 2 years thereafter. And that's generally covered by the PBS. If you want to screen someone, they have to be 70 or over, and you can do it once every 5 years if it's normal. We've talked about this. So the basic workup that we do when we see patients in clinic, we do a DEXA at baseline, regardless of whether or not they've had a minimal trauma fracture. If you can't do a DEXA, and there are reasons why you can't do a DEXA, for example, if someone's had both their hips replaced and they've got a rod in their spine, the only, practical measurement you're going to get out of that is looking at their forearm, and the forearm is inherently inaccurate. So every third of your forearm changes bone density, and it can change significantly. And even if you do it on the same machine, you'll get different readings between years. So if you can't do a DEXA for that reason, a QCT is another valid option. It hasn't really made its way to the PBS yet, but there are centres in Sydney that do them. The one caveat to a QCT is that you'll find the T-scores are generally lower. So it does sort of artifactually lower the bone density on its reading, but it can be an alternative option. We always do an X-ray of the thoracolumbar spine, the reason being you want to see if you can capture silent vertebral fractures, because a vertebral fracture with no trauma in the thoracic or lumbar spine by definition is a minimal trauma fracture. Bone turnover markers. So bone turnover markers basically tell you if the bone is being replaced too quickly, too slowly, or if they're on treatment, you can use it to determine if they're actually responding to treatment. The CTX, which is your C-telopeptide, is actually PBS reimbursed if you do it once a year. I'm pretty sure P1NP is about $50. So we do them in the hospital. That's bulk billed. But if you do it as an outpatient, you could do CTX at least at baseline if you wanted to. The secondary screen. So we do this for all males because osteoporosis is uncommon in a male. Or if you can't really explain why a female in front of you has osteoporosis, in clinic we would do this at baseline. So you do a pituitary panel, you're basically looking to see if they have hypergonadism. We do their celiac serology just to exclude a malabsorption disorder. You do some baseline bloods to see if they've got CKD, chronic liver disease. You want to rule out hyperthyroidism. You need to exclude hyperparathyroidism. Often if patients have hyperthyroidism or hyperparathyroidism in particular driving their reduced bone density or minimal trauma fractures, they improve really quickly when you treat the underlying problem. Vitamin D, because that's really important in bone turnover. If you do a secondary screen, you don't find a cause, you still think it's a bit unusual they've got osteoporosis, there are some additional things you could consider. So screening for myeloma, so EPG, IAPG, serum-free light chains. Tryptase is used if you want to look at for systemic mastocytosis. There have been cases recently where patients have had unexplained osteoporosis. They've had a complete secondary screen completed and it's negative, and then they have a tryptase done and that's quite high, and then they find they've got this lesion. It's rare, but it's something to be mindful of. Tryptase is covered by the PBS, or Medicare rather, and then cortisol, because you want to exclude Cushing syndrome or some form of endogenous or exogenous steroid secretion. So individuals under the age of 50, we always do a secondary screen. You've got to consider what might be driving their bone loss. So chemotherapy is a big one, particularly if they've got breast cancer or some form of hormone-driven cancer, because often they'll end up on hormonal deprivation therapy, particularly if they've got testosterone problems or they've got testicular cancer. If they're on things like tamoxifen or anastrozole, then those are going to lead to reduced bone density. Anti-epileptics are very commonly do it, and steroids. Anyone who's on a high dose of steroid for a short period of time is at more risk of losing bone density than their counterparts. So before I go to the next slide, I just wanted to ask, can anyone tell me what they think the cheapest osteoporosis medication is, public or private? Anyone want to venture a guess? No takers? All right. So I put together a table that basically shows.
Kelly suggested Prolia.
Oh, Prolia. Close. I put together a table that shows all the medications that are available in Australia, both PBS, and I went and looked at some really cheap pharmacies like Discount Warehouse and Chemist Warehouse and Priceline. You can see that if you follow the PBS, zoledronic acid is the cheapest. And actually, if you go privately, so let's say you want to give someone zoledronic acid, they don't qualify for it. That's actually also cheaper, even if you compare it to its counterparts, except for denosumab. But you can see the difference is about $20. So I just thought I'd put this up because this is important, because when you consider treatments and you want to put people on, often we're bound by the PBS, but a lot of these medications have been around a really long time now. And so some of them are cheaper off label if you want to use them. And we'll come back to why you might do that. You can also see that your romosozumab and teriparatide, which are your anabolic therapies, are cheaper than they used to be. And romosozumab is about to make it as a first-line option on the PBS, so it will be much cheaper than a lot of the other options. So T-score or Z-score, I thought I'd put this up because it's important when you're interpreting some investigations when you have a patient in front of you. So the T-score is generally used in most people. It's not validated in someone under the age of 50. So if someone comes to you, they're 49, for example, postmenopausal, and you've done a bone density, you should really go off their Z-score rather than T-score, because there's just not enough evidence on how we should interpret that. It should also be worth noting that as you get older, your T-scores are going to be lower than you would expect, just because you're comparing it to a healthy young adult population. But the raw bone density might actually change between scans, and that's what you should actually go off. So whenever you look at a bone density scan, you should look at the raw bone density, because sometimes that will be discordant with your T or Z score, and that's probably the most important thing to be looking at than anything else, particularly if you think that they may not have osteoporosis. There's a couple of risk fracture calculators I thought I'd just briefly touch on. You've probably come across Garvin and FRAX. They both do different things. Your FRAX calculator has lots and lots of different criteria to use, so your Garvin has lots of criteria, which I'll show in a moment. Whereas your FRAX is basically just what their bone density is. Have they had any falls? How many fractures in the last 12 months? They're used for different things. Your Garvin has a much stronger prediction for minimal trauma fractures, whereas your FRAX has a stronger prediction for hip fractures. So that's just worth bearing in mind. We don't use this very often in clinic, to be honest, but it is sometimes useful if you want to decide if the patient in front of you truly needs therapy or not. So you want to look at their fracture risk. And you'll see that it's often quoted in a lot of the guidelines in that flow chart I showed earlier about, greater than 3% for hip fracture or greater than 20% for minimal trauma fracture in the next 5 years. That's just something worth bearing in mind. So this is what the FRAX looks like. It's very easy. This takes about 30, not even 30 seconds to punch in these details, and then it will give you hip over 5 and 10 years and minimal trauma over 5 and 10 years. This is what the Garvin looks like. It's obviously got a lot more detail, requires you to know a little bit more about the patient, can take a bit longer. We don't do this one as often just because of a time thing. So who do we screen? Australia doesn't recognise screening for osteoporosis, so it's not recommended. What you could do is, it's recommended people over the age of 50, when they come and see you, you could do a risk factor assessment, particularly in people who are menopausal, because we know that they're going to lose bone density as time progresses. Alternatively, if you know that people have some risk factor that's going to predispose them to ongoing bone loss, cancer, therapy for cancer, thyroid disease, then they're worth evaluating as well. We would normally do a DEXA regardless of their FRAX or Garvin score, because sometimes that'll be a little bit more informative, I guess, as time progresses. Because if you find someone's got, say, osteopenia at the age of 50 and they're female, you know by the time they get to 60 or plus, they're probably going to develop osteoporosis. So that's worth evaluating. And yeah, never forget the chronic conditions, and there's lots of them. So just worth keeping in mind. So who do we treat? If anyone has clear osteoporosis, so a minimal trauma fracture, BMD that's quite low, we would treat those generally on spec. And that's because we know that osteoporosis doesn't go away by itself. So without you intervening, they're probably going to have another fracture or be at risk of fractures. People who are high risk, and so if you're not sure, then you can look at their clinical status. So if they're falling lots, they seem frail, they're on lots of medications, they're probably going to be high risk. But you could also do the fracture risk calculator just to confirm that they're at a higher risk of hip fractures. As your population age changes, what you're trying to avoid also changes. So, I mean, in young people, unlikely to get a hip fracture, but you want to try and prevent them getting some other form of fracture. Obviously, as you get older, particularly over the age of 70, hip fractures become quite dangerous. And so you really want to avoid those. And sometimes that's what drives our decision to treat more than anything else. Oh, we talked about this. All right, so I thought I'd just quickly go through non-pharmacological therapy and maybe some things that you guys aren't aware of that have evidence in osteoporosis and reduced bone density, and then go through the medical options as well. So exercise. We always say to our patients, you need to exercise, and patients will say to me, what does that mean? Like, do I just walk? Which is a fair question. So the evidence is if you do some form of weight bearing or weight balanced exercise, and that obviously can constitute a lot of things, muscle training, yoga, tai chi, balance. What doesn't work is hydrotherapy or swimming because there's no weight loading. So that's not encouraging bone turnover. So I recommend patients do something like this that I've put on the screen at least 3 times a week. Ideally more than that, but you know, if it's someone who is scared of falling or doesn't do any exercise, a little bit of exercise is obviously better than none. Vertebral fracture management. So you'll see a lot of patients who come in and they say to you, oh, look, doc, I've got back pain. It's really bad. I've had it for a while. Sometimes it'll be because they've got a vertebral fracture, but patients with osteoporosis can also get microfractures, which you can't detect on imaging, and that causes chronic back pain. The things that really help aren't pharmacotherapy, but it's strengthening the core muscles. So we get our physios to do a lot of core training with them, optimizing their balance. Sometimes they can wear a brace. It's basically anything that helps offset the weight through their back, because that allows the microfractures or the fracture they've got to heal. A vertebral fracture in someone will probably take at least 12 months to heal. So these patients can be uncomfortable for a really long time. Calcium. So we always tell our patients they should have lots of calcium, and they say, what does that mean? What gives me calcium? So I tell them you want to aim for 4 servings a day. That's 1,200 milligrams, because each serving is 300 milligrams. There are different ways to do that. So you can just give them calcium carbonate. 1 tablet of calcium carbonate is the equivalent of 2 servings. So it's a cheap way of getting half. But some people will get constipation with calcium carbonate because you just don't absorb it as well as you do from your diet. So what you can do is use the international calculator, which basically tells you how much calcium they have and where they can get more calcium. It's actually really good. I would recommend everyone has a look at that sometime today. Just practice putting in how much you think you have and see what it tells you and see what recommendations it gives you. It's really useful. There's no good evidence that giving people 1,200 milligrams of calcium increases their cardiovascular risk. That's a big concern a lot of people have. Definitely if you go over 1,200, that's too much calcium, maybe that affects the heart. But if you give them 1,200, which is what you're supposed to get in your diet, there's no good evidence that that's a cardiovascular problem. So don't let that deter you from prescribing calcium to people. Vitamin D. Look, the evidence for vitamin D in preventing fractures in people who haven't had a fracture is not good. But in patients who have reduced bone density or have had a fracture, there's good evidence that you want it to be quite replete. Now, in the general population, you aim for a level greater than 50. In all of the patients we see in clinic, reduced bone density, osteoporosis, hyperparathyroidism, we aim for at least greater than 70 because we know that they need a bit more of their store to regulate their bone turnover. As a general rule, if you give someone 1,000 units or 25 micrograms, that's going to increment them by 10 nanomoles. So if someone comes to see you and they've got a vitamin D level of 30 and you give them 1 tablet a day for 6 weeks, theoretically they're only going to get to 40, maybe 50. So we're a bit more aggressive in clinic. If someone comes and sees me and they've got a vitamin D of 30, I'd probably give them 4,000 or 5,000 a week for 6 weeks, because at worst they'll get to 100 and then you cut it back. But it's more likely that it'll undershoot and they have to have a bit more. Sometimes you'll give patients IM vitamin D. That's good for people who struggle to do it every day or every week. But just bear in mind that there's no evidence that giving IM vitamin D is actually any better than oral. Although you load them with an absolute huge amount of vitamin D, the body doesn't actually process that store any better than if you give it to them every day. This is just taken off ETG. So it's just a rough rule of thumb for how you manage vitamin D deficiency, or if someone's got osteoporosis, having a vitamin D level of 50, although normal for the population, would not be normal for them. So where I would suggest being a little bit more aggressive with how you replace it. All right, so what about elements and vitamins? Boron recently has been shown to increase bone density. We have it in 3 milligram tablets in Australia. You can get it over the counter. There's isoflavones, or like your phytoestrogens. If a patient is postmenopause, there's evidence that giving them 40 to 110, which is like 1 to 2 tablets, can improve their bone density. And magnesium, so 750 milligrams daily, improves bone density, but unclear if that actually impacts on fracture risk. The reason I thought I'd mention these is some of you will come across patients or work in areas where patients are reluctant to accept they have a diagnosis of osteoporosis, and obviously don't want to have treatment because they're worried about the side effects. Alternative measures aside from calcium, vitamin D, exercise would be considering something like this, because these are things they can get over the counter or from a naturopath. They're safe and they have a little bit of evidence. Obviously, these don't compare as well to pharmacological therapies that have been trialed and tested, but they do have some benefit and there is some role for them in some patients. Vitamin K, there was a paper last year that looked at K1 and K2 and showed that although there have been inconsistent results in studies, the more recent one suggests that supplementing with both of these can reduce your bone density, like reduce your loss of bone density, and it can also reduce fracture risk. I'll put in the doses here because you can get them in Australia. So 100 micrograms for K1 and then 45 milligrams for K2, or 150 depending on which brand the patient gets. Very safe, no side effects that are known of, but would be something to consider. Our recommended daily intake is 90 micrograms for a woman and 120 for a man. If someone has a replete diet, this shouldn't be an issue, but you can actually test these, and sometimes you'll find patients have low levels because they're probably not getting enough in their diet. All right, I thought I'd ask this. So can anyone tell me which of the following has been shown to reduce fracture risk? Exclude strontium. That's actually meant to say something else. So just do A, B, C, E. Anyone want to venture a guess?
Any guesses? I'm guessing B, but I've got no idea.
B, yep. Actually, none of them have been shown to reduce fracture risk. But I just thought I'd put it up because a lot of people tell you, and look, to be fair, fish oil has good evidence for a lot of things, but it doesn't have any evidence for reducing fracture risk. You'll often see patients come in and they tell you they're on a stack of vitamins. You ask what they are and they say, oh, I went to see my naturopath and they suggest I go on manganese and selenium because it'll help my fracture risk and improve my bone density. They don't have any harm, but they don't affect your bones at all. All the ones I did are these ones. They're the only elements that have been shown to make a difference potentially. All right, let's go through pharmacological therapy. So there's lots of different options. I've just displayed here a table that shows the dose, how often you give it. We can go through some practical considerations. So alendronate, risedronate, they've been around a really long time. Our grandparents would have been on older formulations of these, and the big issue was reflux. They'd get like this profuse gastritis and reflux, had to sit upright for 30 minutes, couldn't eat or drink anything. Those days have changed. So the once a week version of your risedronate has a special coating on it, which is designed to try to reduce reflux. So reflux is less common with these agents, still can happen. And if someone's predisposed to reflux, they've got reflux or Barrett's esophagus or something, I'd be less inclined to give them one of these agents. All oral therapies for anti-resorptive therapies, so risedronate and alendronate, can cause myalgias. And sometimes you'll get a patient who tells you that they've just got excruciating, life-debilitating myalgias, and it will be from one of these medications. About a fifth of patients won't absorb risedronate or alendronate, so that's worth bearing in mind. So you put someone on one of these tablets, you reevaluate them in 12 months, they're losing bone density still, or they're fracturing. It's probably because they're not absorbing it. About a fifth of them also just won't take the tablets for different reasons. Zoledronic acid, so that's IV, it's once a year, takes about 15 minutes to infuse it. So I know some practices around Australia are opening the option of giving zoledronic acid in the clinic, because the only place you can really do it is in the public hospital, and that requires getting endocrine to approve you and approve the patient, and obviously there's a lot of steps involved. If you wanted to consider doing zoledronic acid, all you need is someone who can do OBS before you give it and after. It takes 15 minutes to run it. We tend to counsel patients to pre-medicate with Panadol or Nurofen before or after. If they're young, particularly female, then we often give them steroids for 3 to 5 days beforehand, because the myalgias they can get afterwards can be quite bad. But the myalgias are in about a third of people, and it gets better the second and third time you have the infusion. But sometimes we have people come into ED because they had zoledronic acid and they're bed bound and they're unwell, and to be honest, that's just a normal reaction, but you can offset some of it if you pre-medicate them. Permigenate is IV, that's done in the hospital. It's a bit more expensive because we don't use it as often. There's no evidence that permigenate is superior to zoledronic acid, so that's worth bearing in mind. Raloxifene is a SERM, which I'll go through in a moment, and then you have your anabolic therapies. So bisphosphonates, we know these work. I've listed the PBS codes here. Essentially, on the PBS, if you want to give someone an oral bisphosphonate, they have to have a T-score less than -2.5 if they've got no fracture, and they need to be greater than the age of 70. But if they've got a minimal trauma fracture, you don't need a bone density and you don't need an age cutoff. So you can give risedronate to someone who has a minimal trauma fracture if they're 35, 50, 75, it doesn't matter. PBS will not discrepant between within that age group. If they've got osteopenia, so let's say you do a bone density on a 75-year-old, they've got a T-score of -1.5, but they've been on steroids for a long time, then they would then they're eligible for oral therapy. Zoledronic acid is a little bit different. The T-score is -3 if there's no fracture, but again, if there's a minimal trauma fracture, then they qualify. And osteopenia is the same. We generally treat people for 3 years with the zoledronic acid, or 4 to 5 for orals, and then we reassess. There's a big push now to not leave people on therapy long term. You want to give them a break. The reason being that their risk of atypical femoral fractures and osteonecrosis of the jaw exponentially increases once you get beyond the 5-year mark. So definitely worth giving people a break if you can. We've gone through the side effects. They're all pretty self-explanatory. Bisphosphonates basically halve your fracture risk from baseline, whatever that is, and they try to stabilize your bone density where it is. Some people will get an improvement. It's a bonus if they do. You're not aiming for an improvement. You're just trying to stop them fracturing. The current guidelines by the IOCGP say if you've got a creatinine clearance less than 35, then you should not give a bisphosphonate. We would tend to go off saying if they're less than 30, consider maybe doing the intravenous zoledronic acid far more slowly. So we don't use that as an absolute contraindication, particularly if they're in hospital. I wouldn't give an oral bisphosphonate to someone with a creatinine clearance less than 30. I would just give them a different therapy. Denosumab, very common. As you know, it's subcut every 6 months. T-score -2.5 on the PBS or a minimal trauma fracture. Look, it's pretty well tolerated. The main side effects are, of course, osteonecrosis of the jaw, atypical femoral fractures. After 2 doses, people are far more likely to get a rebound fracture if their dose is late or it's stopped. And we find that probably about a fifth of patients now, compared to 2 decades ago, who've been on denosumab are more likely to have had a vertebral fracture, just because their dose is missed or delayed or something like that. If you wanted to get someone off denosumab, you can. We normally would bridge by giving alendronate 1 month prior to the next dose, or you give them zoledronic acid before their next dose is due, and then give them zoledronic acid probably 6 to 8 months again later, just to help keep their bone turnover markers relatively suppressed. The reason these people get rebound vertebral fractures is denosumab really suppresses your bone turnover markers. When you come off it, your bone turnover markers actually accelerate and they go above what the baseline was, and that's when you get a fracture. And I've listed the PBS codes there. Menopausal hormonal replacement therapy, very important. So you've got raloxifene, which is a SERM, or you've got estrogen replacement therapy. Tibolone is also an option. We can only get it privately in Australia now, but it's not that expensive. We would recommend doing this within 10 years of menopause and at least 12 months after the last period. Or if someone is really young and has really low bone density or fracturing and has a condition that's predisposing to that, that isn't going to be resolved. So often patients who have been on, cancer therapy, their cancers subsides, they're now 40, they're about to be postmenopause. That's a long time with no estrogen. So we would consider those people as potential candidates for MHT. It's really useful for reducing your risk of vertebral fracture. We also use these if you can't tolerate other therapies. There's a big concern about breast, uterine, hormonal cancers. There's no evidence that raloxifene increases that risk, but it does increase your risk of strokes and clots. And so we always counsel patients about that. You shouldn't use tibolone in patients who have had breast cancer or if they're elderly, because they're at more risk of getting breast cancer again or having a stroke. Romosozumab, so it's about to come on the PBS as first line. Ideally, in an ideal world, you would give an anabolic agent to a patient first who has low bone density, because these build up your bone density, and then you would lock in the benefit with an anti-resorptive therapy like zoledronic acid or denosumab. Unfortunately, the world doesn't work like that because they're expensive. So to access it on the PBS, you have to meet all this criteria. T-score less than 3 at any time in a patient's life. They have to have 2 or more minimal trauma fractures, and they need one of those to be symptomatic in the last 12 months on some form of therapy. It's now contraindicated in patients who have ischemic heart disease or strokes, and on the PBS, you can only get 12 months. So you get it for once in your life. So we tend to reserve this for patients who come and see us and they've got a bone density of, minus 3.5, they're fracturing, they're the candidates you would give this to. There is an increased risk of osteonecrosis of the jaw and atypical femoral fractures. Very, very rare, but there are some case reports, and you can't use it on the PBS if you've already given them teriparatide. Teriparatide, it's been around a little bit longer. It's basically recombinant PTH, and it meets the same criteria on the PBS as romosozumab. On the PBS, you can give it for 18 months. The reason that there's a limit to teriparatide is when they did it in the rats, some of them grew sarcomas. It's never been shown in a human to do that, but you've got to be cautious how long you give it for. And you can't give it to people who have had bone tumors or radiotherapy for that same reason. Teriparatide is once a month, once a day, or once every second day. We would normally measure their calcium after a couple of weeks because sometimes their calcium can go down. Romosozumab is 2 injections every month. So it's basically 2 preloaded pens that are half dose each, and the patient gets it on either side of the abdomen once a month. So it's a consideration for both of these because they require injections. If someone doesn't like injections, teriparatide's a difficult sell. All right, so we've gone through all of those. Let's go through some cases. I think at the end I go through the rare side effects. Does anyone have any questions before I go through some cases?
Yeah, there just was a question. What dose of steroids do you give pre-cluster effusion?
Oh yeah, so we would normally give prednisone 25 milligrams for 3 to 5 days and then stop.
Right, thank you.
All right, so case 1, you've got a 35-year-old lady. She's had a distal forearm fracture, which constitutes minimal trauma. This is her bone mineral density. So she's got osteopenia in the femur and the spine, but she's got osteoporosis in the left radius. What does someone want to do next?
So we've got a secondary screening listed
Yeah,
there.
that's it.
Yep.
Secondary screening. So you do the secondary screen, you find they've got primary hyperparathyroidism, you treat that by removing the parathyroid adenoma, you repeat their bone density in 2 years, and usually you'd find that would improve. In a young person, It should improve. Young people shouldn't have reduced bone density. If you had ongoing bone loss, then you could consider bisphosphonate therapy. And if it's a 35-year-old who's had a minimal trauma fracture, then technically you can give them zoledronic acid, you could give them denosumab, or you could give them something off-label because of the age cutoff. But yes, secondary screen, very important. All right. Second case. So you've got a 69-year-old lady, postmenopausal. She's had a T11 crush fracture, which is minimal trauma. You've picked it up incidentally, but you note that she's been on prednisone 5 to 10 milligrams for several years for severe arthritis. Her first initial bone density showed that her T-scores were, minus 1.6 to minus 2.4, and she's been on denosumab for the last 6 years. You can see that her repeat BMD shows T-scores that are pretty similar. What does someone want to do next? Do you want to change her therapy, leave her therapy, do nothing?
Would we consider a bisphosphonate, given she's got the vertebral crush fractures and there's more evidence for bisphosphonates?
You could.
Vertebral fracture, but then she's not really losing much bone mass. So if she's happy on the Pronamb,
yeah, so I deliberately withheld her raw bone density on the repeat, and you can see that it's actually better. So she's actually gained a little bit of bone density. You're right. If someone has a vertebral fracture, bisphosphonates are better, but denosumab is better at locking in your bone density, and people over time will accumulate a little bit of extra bone density on denosumab. So if someone's on denosumab like this lady, and you look at their raw bone density, you'll see that, like in this case, it's improved. We would just leave it. We wouldn't change therapy. If, on the other hand, she was losing bone density, we would normally stop the denosumab and go to zoledronic acid to prevent further bone loss and fractures. So really, this is a really good case of where your T-scores are not very helpful, but your raw bone density is. So that's why when you send someone off for a DEXA, it's really useful if the facility doing the scan reports T-scores and bone density. Sometimes you'll find they don't report the raw bone density, and that's really unhelpful if you want to track them across time. All right, you've got a 60-year-old lady.
Can I ask something?
Yes.
In these cases, is there any point in adding in any of those ones that you mentioned, like magnesium and boron and isoflavones and so on?
Look, probably not. I find that sometimes a balance with these patients, because you want to balance how many therapies and information you're giving them versus the actual benefit they'll get. If someone is willing to have denosumab or bisphosphonate therapy, you think their diet's okay, their bloods look pretty reasonable, I wouldn't pursue boron, magnesium, any of those. If, on the other hand, someone's a little more reluctant, they tell me, oh, I'm going to go away, chat to my GP, do some research, think about it, they're the sort of people I'd probably put on something else, because they might get a little bit of gain, and then if they change their mind, they've at least got some therapy.
Okay, thanks.
All right, so you've got a 63-year-old lady, T-score minus 3.4 in the left radius, so quite low. Even the spine is quite low. We've got a history of small bilateral adrenal adenomas, and you've found that they've got some exogenous, some extra endogenous mild cortisol secretion. They haven't had any minimal trauma fractures. What would you do? How would you treat them? Do you want to treat them? So I guess there's a couple of issues in this case. One is that you've got a postmenopausal lady who's 60, so she doesn't meet the cutoff of 70. She hasn't had any fractures. Her bone density looks terrible, and you know that she's got ongoing excess cortisol secretion, so she's going to keep losing bone density. Unfortunately, on the PBS, you're kind of stuck because you can't give them the therapies we talked about on the PBS because they don't technically qualify. This patient was actually commenced on denosumab privately, which is about $100. They haven't had any fractures. The bone density has actually improved after 2 years. The plan would be to transition them off denosumab because they're young, and to probably lock that in with an oral bisphosphonate So for patients like this, unfortunately, the PBS does not discriminate and allow you to treat them easily. But you've got the table that I put up before, which shows that you can cheaply treat them, whether it's denosumab, IV, say zoledronic acid, alendronate. They would all be very reasonable therapies. The issue is that if you went off the PBS alone, you wouldn't treat this person, and they will end up fracturing. Their bone density is terrible. It's likely to get worse. For someone like this, we would actually counsel them about considering anabolic therapy. If someone has a T-score of minus 3.4, they will generally do very well with anabolic therapy. All right, you've got an 80-year-old lady. She's had prednisone for several years. These are her bone density when she was first done was minus 3.9, minus 4, so pretty low. She was given risedronate for 2 years. Then she was given denosumab. Then she went back to risedronate. You can see that she fractured whilst on denosumab, so she's very high risk for fracturing. You do her bone density 10 years later, and you find that, to be honest, nothing's really changed. Her spine is probably overestimating her bone density because she's got osteoarthritis in the spine. What do you want to do next? May I ask you differently? Who wants to leave her on risedronate?
Any takers?
Or who wants to do something different? Who wants to give her a different treatment? So look, I guess in this case, there are a couple of things that stand out. One is you've got a postmenopausal lady who just by her age alone with her bone density qualifies for treatment on the PBS, so that's not a problem. But you can see that she had prednisone for a reasonable amount of time. It was a reasonable dose. She's been on therapy, and despite her therapy, has not incremented her bone density, and she's fractured when she was on therapy. So there's no real right or wrong answer. You could equally just leave her on a bisphosphonate and accept that she might fracture again because you know that the bisphosphonate she's on is not going to improve her bone density. Or you could put her on zoledronic acid. Maybe she's not absorbing the bisphosphonate. So maybe she's had years of oral therapy and hasn't absorbed it at all. And if you give her IV zoledronic acid, you know that she will absorb it, so you'll lock it in. That's on the PBS. Or you could give her anabolic therapy, like teriparatide, and build up her bones. All of those would be reasonable options to consider. So I guess the big talking point for this case is if you have someone who's been on lots and lots of oral therapy and their bone density doesn't improve or they fracture, you have to consider, are they absorbing the therapy and are they better having something else that bypasses their alimentary system?
Just a question, Liam. So, well, I know in the GP setting, I haven't prescribed anabolic therapy. I usually just stick to the bisphosphonates and the Prolia. Is that something that we would be then getting a specialist opinion for, or we, I don't know, any of the other doctors here prescribing the anabolic treatment?
Anabolic therapy, the initial prescription, romosozumab particularly, has to come from an endocrinologist, but continuing the therapy, provided they are reviewed regularly by an endocrinologist, can be continued by a GP. If you thought someone was a candidate for anabolic therapy, like this lady, you could identify that and refer them to an endocrinologist for that opinion, and then that gets them in the system to start getting the therapy.
Great, thank you.
All right, you've got a 72-year-old lady. She's got acromegaly, adrenal adenomas. She's got other risk factors for bone loss. She had a neck of femur fracture with no trauma. And you look at her bone density and it shows osteopenia. What do you want to give her? Does someone want to start with denosumab? Do they want to start with bisphosphonate?
Let's go bisphosphonate.
Yeah, so I appreciate that in the GP community, zoledronic acid can be hard to access. So if you can't access it in your area, then an oral bisphosphonate would be a very reasonable option. If, on the other hand, you can organize zoledronic acid, whether you've got a clinic or you've got a hospital that will do it in their medical day unit for you. I find a lot of patients nowadays are opting for zoledronic acid because of its lifestyle. A, they'll absorb it better, and B, lifestyle. You only have to have the treatment once a year. It's once every year for 3 years. They're not having to take a tablet all the time. Most of the side effects they're not going to get anyway. So just from a convenience perspective, and it's also cheaper, it's a better option. But we realize that it's difficult to access it in a lot of places. And so then oral bisphosphonate would also be very reasonable. Both those options would be on the PBS in this case. The last case I have is a 62-year-old lady. She's got SLE and rheumatoid arthritis, so conditions that are going to predispose her to bone loss. You can see she's been on steroids for a long time. She's had lots of fractures. She's been on bisphosphonates and denosumab therapy. She got osteonecrosis of the jaw. We gave her teriparatide off-label for 4 years and had no issues. Osteonecrosis of the jaw healed. What do you want to do now that you're going to take her off the teriparatide? How would you lock in the gains and the reduced fracture risk? Would you give her no treatment, or would you lock it in with a bisphosphonate or denosumab? So I guess in this lady, she's young, so already it's difficult from an age cutoff. However, she has had multiple insufficiency fractures, so that means that she will qualify for anti-resorptive therapy on the PBS. She paid for teriparatide privately because she didn't respond to other therapies and was still fracturing. And you know that she's got autoimmune conditions with steroids, so she's going to keep having bone loss and likely have an increased fracture risk. So this is a very high fracture risk patient. For someone like this, and you'll see some of these people come back to you from a clinic or they come out of hospital, they haven't seen someone for a long time. It's very reasonable to lock in their therapy with something like denosumab. So denosumab is very good at what we call locking in gains that you've got in bone mineral density, because patients don't lose bone density on denosumab. If they do, it means they've got some underlying predisposition to fracturing that hasn't been identified, and that's uncommon. So denosumab is very effective. It's subcut. It would be on the PBS for this indication, reduces their fracture risk, and the risk of osteonecrosis of the jaw is less with denosumab than it is with bisphosphonates based on the studies that have been done. So it would be a very safe option. You'll see, yeah.
Sorry, just a question. What is the risk of osteonecrosis of the jaw again for this patient?
So next slide.
Yep, beautiful.
So osteonecrosis of the jaw, exceptionally rare outside of anti-resorptive therapy. If you do a Google search of osteonecrosis of the jaw without osteoporosis, it's almost unheard of. So we call it medication-related osteonecrosis of the jaw. There are 2 agents that don't cause it. So raloxifene and teriparatide both have no risk of ONJ. And teriparatide actually increases your healing if you have ONJ. So this lady had ONJ, was put on teriparatide, and it rapidly improved her healing. The risk is about, well, it's less than 1% in most patients. After about 4 years of anti-resorptive therapy, it goes to about 0.21%. This is probably overestimated because the majority of patients who have been found to have osteonecrosis of the jaw are cancer patients. So in the cancer population, you give them denosumab or zoledronic acid every 1 to 2 weeks, and that's high dose. So cancer patients get denosumab 60, 120 milligrams, weekly, every second week. Zoledronic acid, you give them 4 milligrams every week, 2 weeks, and it's for bone metastases. So obviously they're at a much increased risk of osteonecrosis of the jaw because they're getting it so often. In a lifetime, you might only give your patient 3 doses of zoledronic acid over 3 to 4 years. So the risk is really low. It can manifest in different ways. So ulceration and erosion is what the dentist will often see, but they can get dry socket where it's non-healing, it's dry. They can get fistulas and infections. Sometimes the jaw will fracture. So there's lots of different ways it can present. If you get osteonecrosis of the jaw and they're on therapy, you have to stop that therapy. And you've really got to consider the fracture risk versus allowing the necrosis to heal. If patients are going to go for dental procedures, or you're seeing them for the first time, what I normally tell them is go to your dentist, tell them you're going to be starting denosumab or zoledronic acid, and ask them if you need any dental therapy in the next 12 months. Because if they say yes, they should do it sooner rather than later. In saying that, if people need to have an emergency, extraction of their tooth, have been on a bisphosphonate is not a contraindication to that. We just have to monitor them a bit more frequently. If they're on denosumab, we would recommend they have their dental procedure right before their dose is due, because that's when it's wearing off. The same with zoledronic acid. Atypical femoral fractures, another really important side effect of treatment. It's about 3.2%, or not even that. So very rare, almost as rare as osteoporosis of the jaw. In recent times, there have been studies that have shown that if you're on anti-resorptive therapy, you're also at an increased risk of other atypical fractures. So things like sternal fractures, clavicular fractures, skull fractures. They're a little bit more common than your baseline, but it's still less than 1 in 100,000. If you suspect someone has an atypical femoral fracture, or you're worried they might develop one, there's a couple of ways you can assess for that. One is that the standard patient will get a prodrome where they get pain and aching in both their thighs for several months before they see you. You can do an x-ray of both their femurs or an MRI, which is more specific, and you're basically looking to see if the cortex is thickening or looks funny. The way we treat this is they have to have both legs pinned. If you find an insufficiency fracture in one femur and you treat it with a pin, the other side has been shown within 12 months of that occurring to also fracture. So orthopedics would pin both femurs at the same time. Still very rare, but something to be mindful of. And the magic number is 5. Once you get beyond 5 years of treatment, your risk will exponentially increase. What we normally do is stop treatment at 5 years, give them at least 12 months off treatment. If they're high risk, then we'd restart therapy sooner rather than later. But there's no good way to guide when you restart therapy. So doing bone densities and bone turnover markers will not give you any information about when to restart therapy. So we do that based off a clinical risk, balancing this risk versus fracture risk. That's everything. I've included here a table for how you can adjust if people are on steroids based on their age. Probably more useful if someone's young, and it's to do with your fracture risk that you calculate when you use Garvin or FRAX. So you can see that young people, their risk can go up by 25 to 30% based on their steroid dose. So I just thought I'd include that as a reference. All right. Any questions about any of that or anything about osteoporosis in general?
That was fabulous, Liam. Thank you. So many gems in there, and especially I like the point, like, yeah, don't be afraid to use medications even if they're not on the PBS. I know I've used the zoledronic acid for a patient that was, her T-score didn't quite cut the mark, but it was only about $115, I think, and that's pretty good value if you're only having it every 12 months. So yeah, that's fabulous. Any questions from the crowd? Yeah, another thank you that, yeah, the cases were very helpful too.
Could I ask a question, please?
Of course.
Hi, thank you so much for the talk. I just had a question regarding reviewing bisphosphonate treatment after 5 years to avoid the increase of risk of complications like osteonecrosis of the jaw. Given that bisphosphonates are shown to remain in the bone for so long, if that patient just receives a 12-month drug holiday and then is commenced again, is there actually much evidence that their risk of adverse complications decreases?
Yeah, so studies have shown that if you stop therapy after 3 to 5 years, their risk of an atypical femoral fracture or osteonecrosis of the jaw dramatically drops, but it doesn't go back to baseline. So if I saw someone with osteoporosis and they had no treatment for 5 years, their risk of these complications is essentially 0. If you put someone on anti-resorptive therapy, that risk increases ever so slightly by the time you get to the 5 years. Then if you stop treatment, it doesn't go back to 0. Some of that will be to do with the fact that, like you said, you've got these agents that last a really long time in the bones. They can last for, decades in some people. But there's probably an independent effect of that as well, because these agents probably alter your skeletal structure slightly. So they're still slightly predisposed. Once you restart therapy, the risk starts to increase again, and it probably increases a little bit more than it would have the first time you did therapy, because they've already been exposed, they've got these agents on board, their skeletal structure has been affected by these agents already. So the risk is still small, but every year that they're not on treatment decreases that risk a fair amount. So the longer you can keep someone off treatment in between drug holidays, the better it is for them from a side effect profile. So if someone is mild to moderate, so let's say, someone comes in 75, has bone density of, minus 2.6, you give them on zoledronic acid for 3 years, their bone density sits around minus 2.3, no fractures, we would leave someone off therapy probably for at least 2 to 5 years. If their bone densities every 2 years don't change, so they don't get worse and they don't fracture, we will just keep monitoring.
Okay, thank you so much for that.
And we just have another question. If the Prolia doesn't cause, sorry, now I've lost that question. If the Prolia doesn't, I think it was, sorry, I can't remember. If the Prolia doesn't cause a reduction in the bone density, is it why do we still check every 2 years, or do we still need to check every 2 years?
Yeah, so if someone's on denosumab and they're not fracturing, you would expect that their bone density should not be changing. If anything, it should be improving. But there are a proportion of the patients you'll see who will still lose bone density on denosumab, which is unusual because the mechanism of denosumab is that it suppresses your bone turnover markers completely, like they're undetectable. So if they're not detectable, if they are detectable on denosumab, that has to make you think that there's another condition that's driving that. The options for that would be something like osteogenesis imperfecta. Maybe they've got such severe vitamin D deficiency that they've actually got rickets or something else like that. Maybe they've got some other chronic condition you haven't found. That's when we start to consider maybe denosumab is not the most appropriate. Otherwise, we would just leave it. Do you have to do it every 2 years? Look, I guess you don't. If they're not fracturing, you think they're tolerating the denosumab, you could stretch out how often you're monitoring, but the PBS will cover you to monitor every 2 years once they're on therapy.
Right, and I've just got one more question, just based on the bone turnover markers. Is that something, all those fancy tests, that we should be leaving to the endocrinologist, or we've got our patients that we're monitoring?
Yeah, sure. So look, bone turnover markers are useful. If someone came to you with osteoporosis, let's say they're 65, you do a secondary screen, it's a bit abnormal, there would be value in doing a bone turnover marker, because when you do the bone turnover marker, it gives you an indication of how aggressive their osteoporosis is, and also how likely it is they're going to respond to a therapy. So the general rule of thumb is if someone fractures, their bone turnover markers are going to be increased for 3 months afterwards, and that's normal. You should expect their bone turnover markers to be high if someone is fracturing, because it means they've got new bone that's been turned over. If, on the other hand, someone doesn't fracture and you see them in clinic and their bone turnover markers are really high, it does suggest that they may not respond as well to anti-resorptive therapy, because you may not get the suppression you need, and it means that there must be something else that's driving that bone turnover. If the bone turnover markers are already on the lower side, and then you're going to start therapy, then that you would expect that they will respond really well. They're also useful once you've started people on therapy, because if someone's on an oral bisphosphonate and their bone turnover markers are normal, like I'm talking mid-range or high, that means one of two things. They're not taking it, which is probably about a fifth of patients, or they're not absorbing it, which is another fifth of patients. So 40% of the patients you put on oral bisphosphonate doing a bone turnover marker will tell you if they're responding to treatment or not. That's important, because if you've got, say, a 90-year-old who you don't want to get a hip fracture in, you put her on risedronate, a bone turnover marker 12 months after therapy is essentially unchanged, she's really high risk of fracturing her hip. So if you just pursued risedronate for 3 to 5 years, she'd probably get a hip fracture in that 5-year time period. CTX is PBS covered, so you don't have to wait for an endocrinologist. You could do what we like, because we do it obviously for anyone who comes and sees us in clinic. It's really useful if someone's had a baseline CTX before treatment. It just tells us what their bone was like before agents started interfering with the skeletal structure. It's not essential. Look, you can treat people without bone turnover markers, but it can provide you with very useful information, particularly from a compliance and responding perspective.
Thank you. I wanted to thank Dr. Liam Clifford for presenting for us this morning. It has been super informative and overwhelmingly positive comments in the chat section. Thanking you. For the evaluation, I will email that out because it seems to not be working. Apologies, Dimity. So I'll send that with an email to all of you after this. And I wanted to thank everyone for spending their morning with us. This is a really great program that we are really passionate about, and it's good to see that you guys are just as passionate too. So thanks very much and enjoy your day.
No worries. Thanks all. Have a good day.
Thank you. And we'll see you, I think the next session is the 31st of July. So we've got a little break over the school holidays. So we'll see you back there nice and early in the morning on a Wednesday. Thanks again, Liam. That was fabulous.